Welcome to tonight's master's class. My name is Dr. Ken Urish, and I'll be your moderator for tonight's class. We have an excellent master faculty with us to discuss the topic of current concepts in the management of implant infection and bacterial contamination in complex orthopedic procedures. This is a particularly timely subject. I'm really pleased to introduce our master faculty, starting with myself. I'm the Associate Professor and Director of the Arthritis and Arthroplasty Design Laboratory at the University of Pittsburgh and an Associate Medical Director at the McGee Bone and Joint Center. Also joining us is Dr. Nick Bernthal. He's the Chair and Executive Medical Director at the David Geffen School of Medicine at UCLA in Los Angeles, California. Finally, also, we have Dr. Jesse Otero. He's the Associate Professor at the OrthoCarolina Hip and Knee Center and co-director of the Hip and Knee Research at OrthoCarolina Research Institute and director of the Periprosthetic Infection Center in Charlotte, North Carolina. To our audience, please make frequent use of the question and answer button at the bottom of your screen. Again, it's great seeing everybody tonight. My name is Ken Urish, and the title of my talk is Bad to the Bone, Biofilm and Orthopedic Infection. Again, I'm director of the Arthritis and Arthroplasty Design Lab at the McGee Bone and Joint Center. These are my disclosures. And at the ad lab, our model is using clinical studies to direct the basic science research that we're doing to develop new translational approaches or new treatments for how we're treating periprosthetic joint infection. And we all in the audience already know that orthopedic infection is a very big problem. When I'm explaining it to other faculty members or people outside of orthopedics, I remind them that the most common major surgical procedure in the United States is hip and knee arthroplasty, and periprosthetic joint infection is the biggest source of our failure. For comparison purposes, overall, the rates are relatively comparable to the incidence of stroke. And when I'm thinking about how I treat periprosthetic joint infection, it's actually interesting. Not so long ago, there was a great article in the New England Journal of Medicine talking about the parallels between cancer and infectious disease. And it was actually really looking at this from the perspective of our immune system and how our immune system initially looks at cancer and an infection from essentially the same prism. And this is a great analogy because our outcomes are also relatively similar. When you're talking about outcomes with cancer, ultimately what people really care about are, am I going to live? And what we've learned more recently is that mortality with joint infections is actually comparable to cancer, rather high, with rates anywhere between 15 to 25% mortality at 5 years. And from a perspective, again, this analogy with cancer, this isn't so far off of what we see with 5-year survival in cancer. In fact, if I tell a patient that they have a joint infection, their 5-year survival is lower than Hodgkin's, breast cancer, melanoma, or prostate cancer. It's a really big problem. And so the objectives with my talk are, one, from a clinical perspective, what are our treatment outcomes looking like for periprosthetic joint infection? And then the second point on the basic science side, why is it so hard to control these infections? And to talk about this, you really need to understand with periprosthetic joint infections, what are your options? So if a patient walks into my office and they've only been symptomatic for a few days, we call this an acute periprosthetic joint infection. And our treatment modality of choice here is something we call a DARE. It's a debridement with antibiotics and implant retention. What we're trying to do is salvage the implants and save them. If this same person comes into my office a few months later and they say, my hip or my knee has been hurting for a month or for a few months, we call this a chronic periprosthetic joint infection. And this is something, and it's outside sort of the scope of the talk, where you could either do a single stage or a 2-stage. The differences really between them aren't that different from the perspective that the outcomes are somewhat comparable. And so now the patient's been symptomatic for a long time, and the types of surgical treatments I'm using to take care of these are very different. And finally, we have sort of the salvage case where they've had the infection and we can't get rid of it, and they continue to present, and we don't have as many surgical options. And so what can we do to try to salvage the limb and prevent an amputation? And so for acute periprosthetic joint infections in terms of outcomes, this really does a great job of illustrating how there's so much more to optimize and improve. So this is actually one of the first clinical studies our group did, looking at the implant survival probability over the course of about 2 months after a DARE. So this is an acute periprosthetic joint infection, and the presenting, and what's our failure rate over the first 2 years? And essentially, the failure rate was about 60%. And if we optimize things as much as possible, our failure rate was still about 40%. And so if you're walking into my office with an infected joint, and I tell you that our first line treatment is roughly a 50-50 chance of working, that's unacceptable. Comparable for chronic periparasitic joint infections, I really like to focus a lot on a 2-stage. The results aren't that unbelievably different. And I like to open up with this great classic article in JBJS looking at the fate of spacers. And so in a chronic periprosthetic joint infection, we remove all of the components. You have IV and you get a spacer. You have IV antibiotics for about 6 weeks. And then we wait a number of other weeks to a few months before we go back to put your new components in. And classically, we talk about failure rates being about 10 to 20% in this group. But that's when you look at reoperations after you have final components. The unique thing about this manuscript is they actually started at the very beginning. And typically, when you talk about a clinical study, you have a consort diagram. This is how many people that we initially started with, and then it shows how people were excluded or included as you went along your treatment pathway. And this is one of the most confusing consort diagrams I've ever seen, but it does a great job of illustrating how complex a 2-stage procedure can be. And so we're starting with about 650 patients, and we're ending up with about 260 that actually finally have final components with no other reoperations. And if you look at 2 stages overall, the outcomes are really, in the grand scheme of things, as our gold standard, the failure rate's anywhere between 10 to 40% if you look over the first 5 years. And it gets even worse with chronic periparasitic joint infection when you fail that initial 2-stage. So we call these repeat 2 stages, and some more classic work that has come up more recently has demonstrated that the failure rate, if you fail the 2-stage and I need to do another 2-stage, is about 60%, which is basically our last-ditch effort to try to salvage your limb. So the second part of our talk is, from a basic science perspective, well, why are these outcomes so bad? Why is the infection so difficult to control when these implants become infected? And the short answer is, well, biofilm. And many of us know what a biofilm is, but I always like to sort of review how I approach this. Your biofilm, when I think of bacteria, if I'm talking to some undergraduates in a microbiology class, you think, or my patients, they think of the bacteria as floating around in solution, just as a single cell planktonic organism. But from a pathology perspective in the body, the bacteria aren't just floating around as single cell organisms. They're actually forming a 3-dimensional community on the implant. And so first they attach, they build this 3-dimensional extracellular matrix, and they become a community. And this is their normal pathologic state. It's not planktonic, it's a biofilm. And so for a DARE, which is our acute periparasitic joint infections, well, why can't we get rid of the biofilm when it's on an implant? And the work that we've looked at to sort of approach, well, why are our failure rates from a mechanistic standpoint so bad? A DARE is really 2 sort of separate pieces. You have the part of the DARE where you're irrigating with lots of fluid, and then the second part where you're debriding and you're trying to clean out as much of the joint space as possible. And so if we kind of look at these 2 different scenarios, well, how much biofilm do we really remove when we're using irrigation? And so this was actually using some bacteria that has luciferase, so it under the right conditions, it glows. And if we look at the 3 main components that are used in a total hip or a total knee, this is before irrigation on the left. It has a nice signal. And then after irrigation, you can see that the signal drops. And in the cobalt chrome here, only because I'm comparing it with the cement and the polyethylene, it looks like 0. But if you look over here on the graph, we're really only removing about 90% of the biofilm when we're irrigating the implants. And that's good, right? It's much better than nothing. But the doubling rate for the bacteria are anywhere between 10 to 30 minutes. And so very quickly you're back where you were before. So it's a useful, important technique in the surgery, but it's not cleaning the joint out completely. So the reason why it's so hard to wash this off was some really great classic work by Paul Studley. And so they actually videoed a portion of the biofilm when it was on the implant. And so this here is the actual kind of aggregate of the biofilm. And what they demonstrated, and you'll see in this, what you'll see in the video here, is that as they're giving it a flow, the biofilm is actually behaving like a viscous fluid adhered to the surface, and it's moving across the water or across the implant. So when we're trying to wash the biofilm off the implant, some of it's falling off, but a lot of what we're doing is really spreading it around. So that was the first part, why we can't wash the implant off. But once we have cleaned some of the biofilm off the implant, why doesn't antibiotics finish the rest? And this is where I really like to use the example of the the antibiogram that we get when we send these cultures to the microbiology lab. And so when I'm doing cultures in the OR, they will come back positive, and then a day later, what better way to pick your antibiotic than actually testing the concentrations of antibiotic on that organism? And so you get the sensitivity. And if I send this is a Staph aureus culture, so it's methicillin sensitive staph, it's sensitive to all the antibiotics that are on this sensitivity chart. But yet the antibiotics alone aren't getting rid of the infection. And so, when they're doing these tests and they're showing you that the antibiotic is, or that the organism is sensitive to that antibiotic, the test that they're doing is really planktonic. These are the bacteria that are floating around. Whereas this culture was actually from a sonicate. It's the actual biofilm that's on the implant. And when you compare the planktonic to the biofilm, what you learn is that the biofilm is highly antibiotic tolerant. And so these were a series of different Staph aureus isolates across a number of different antibiotics. And the blue dots on the left here are when we were culturing and looking at the MIC, the minimum inhibitory concentration, to prevent growth when it was planktonic. And when we took the same isolates, but we grew them as a biofilm, you can see how much increased the dose of antibiotics that we needed to try to stop the growth, to the point where we were up at 1,000 micrograms per mil, our limit of sort of detection here, which is just an unbelievable atomic dose of antibiotics that you would never be able to achieve clinically from a pharmaceutical perspective in treatment clinically. And so the Staph aureus here, there's a huge variation in the biofilm antibiotic sensitivities. And what we're seeing is that the biofilm becomes highly tolerant to the antibiotics. And it's not just the antibiotics, it's also antiseptic solutions. And so this is, again, looking at the y-axis, how much biofilm the colony forming units is left. And this was looking at the untreated, our control that we always use in our lab, the antibiotic concentration for 24 hours. And we were looking at propidium iodine, hydrogen peroxide, and chlorhexidine. And the control between the antibiotic and these three antiseptic solutions, we're here comparing apples to oranges because this is 24 hours of cefazolin, whereas in the OR we're only using 5 or 15 minutes of these antiseptic solutions. But what this is showing you here is that these antiseptic solutions are really useful to use. They're debriding, they're destroying a lot of the biofilm, but they're not getting rid of all of it. And so the question becomes, well, why can't these antibiotic solutions or antiseptics get rid of everything? And there's three main reasons that I sort of look at why this biofilm is so tolerant. One is the metabolism. The biofilm portions of the bacteria in it have a very low metabolism, and so it's much harder to kill them. This is mediated through toxin antitoxin systems, and then also finally with mass transport. So if you have a really thick biofilm and you have a very low concentration of antibiotics, it takes a lot more effort for that biofilm or for the antibiotic to be able to diffuse through the biofilm to get to the very bottom. And then the concentration of that antibiotic is even lower. And, so some of this initial work that really demonstrated this very well was actually more recently in Nature Microbiology. And the thought process is essentially, if the bacteria has a very low metabolism, and the antibiotics are disrupting that metabolism. If there is no metabolism, you're not going to kill the bacteria. And this is actually sort of how toxin antitoxin systems work. So the toxin is basically something that will destroy something in the bacteria to shut it down. And I use RNase here, right? And so with toxin antitoxin systems, it's a specific RNase enzyme that is basically inhibited. But when it sees a stress like an antibiotic, it releases it, and that RNase goes around through the bacteria and chews up all of the mRNA. And if you chew up all the mRNA, there's no protein translation. And from there, you have no actual cell growth or metabolism. And so penicillin works, and this is a great example. Penicillin works by disrupting cell wall synthesis. And so if I have a lot of penicillin around my bacteria, but my bacteria isn't growing at all because I've shut down the metabolism, it doesn't matter how much penicillin is there, it's not going to kill the bacteria. Now, at some point, that penicillin, the concentrations are going to go down and it's going to go away, and then it allows the bacteria to turn back on. Well, the penicillin isn't there anymore, and it can make as much cell wall as it wants to, and so that's why that antibiotic becomes intolerant. So we were talking a lot here about the basics of why doesn't a DARE work, but well, what about two-stage? And so in a two-stage, we take everything out, we put a spacer in, we wait 6 weeks with IV antibiotics, we wait at least another 6 weeks as what we call an antibiotic holiday to make sure that the infection is gone, and then we will consider, are we going to give you new implants or not? And so, well, if this biofilm is really antibiotic tolerant, can we see the same thing when we're doing a two-stage? And so this was a study that we did where we took the spacers that we were removing. Again, they had antibiotics for 6 weeks, and then there was this antibiotic holiday for at least another 6 weeks, and you have to remove that spacer. And the logic here was, well, if that biofilm is truly antibiotic tolerant, we should see some of that viable bacteria still present on this theoretically sterile antibiotic spacer. And so there's a few different ways you could approach this. One, we could look at the DNA, if there's any DNA left on the spacer. But this is when it becomes a little bit like Jurassic Park, right? The DNA is still left inside the mosquito that's in the amber, eons later after dinosaurs have died. So that's not a really great approach. Messenger mRNA has a half-life of less than 5 minutes. And so that's a really challenging thing to try to pull off and see if you can see a signal for that. But ribosomal RNA has a half-life of a few days to a week or two. And so if we can detect ribosomal RNA on this spacer that hasn't seen any antibiotics for more than 6 weeks, that gives us a good idea that there was some viable bacteria present, at least at some point after this initial treatment. And so when we did this study, we had about 10 spacers, and these were a whole bunch of different initial organisms. And we did this ribosomal RNA analysis. And what we found was that in 4 of those 10 samples, we were seeing the initial strain ribosomal RNA on our initial cultures, which is very strong evidence that there was still some viable bacteria after we were done with those 6 weeks of IV antibiotics. And so we did this using single genome analysis, where we could take that ribosomal RNA off of the spacer, we would use PCR to amplify it, and then go back and compare it to the ribosomal RNA signature on our initial cultures. And we were finding that they would match almost half the time. And if we actually use quantitative RT-PCR to look for how many copies of the ribosomal RNA were actively on the spacer, about 33% of our samples still had a strong RNA signal, demonstrating that there was a relatively high amount of bacterial RNA still present on the sample, giving you very strong evidence that biofilm is just really tolerant to antibiotics. And then even after we're doing this massive amount of antibiotics, we can't get rid of it. So in conclusion, our first objective was clinically, what do our periprosthetic joint infection treatment outcomes look like? And essentially, the failure rates are high. And number 2, from a basic science perspective, why is it so hard to control? And it's because that biofilm is really tolerant to antibiotics. And I like to use this sort of throwback poster to tuberculosis. So this was one of the old Christmas seals, start back from the 1960s, trying to get people to look at tuberculosis. And it's a really great example because people in general understand that if you've got TB, it is something that is going to be around forever, and you need months, 6 months to 1 year of antibiotics before you're going to get rid of it. Joint infection is very much the same kind of thing. It's like TB. It's extremely hard to get rid of. And to get rid of it, you need long and very hard amount of treatment to be able to get rid of it. And even then, a lot of times, just like TB, it's going to fail. So sort of where does this leave us? Like, what's our solution? And this is one of those classic examples that the best treatment is prevention. And so this is a really great article from back in 1969 from Dr. Charnley himself. And they were talking about everything that they were doing in the OR, laminar flow primarily, to decrease the amount of infection because it was the biggest problem they had when they were starting to do total hips. And it's really great because in the conclusion, he has this remark: overall, the incidence of our joint infection remains at about 1.3%. And this was for primary total hips. Today, I quote to my patients that the incidence of periparasitic joint infection in their lifetime is going to be 1 to 2%. And if I'm doing a revision case, it's going to be as high as 5%. And so from 1969, when we first started doing primary total hips, our incidence of infection hasn't changed. We're doing a really bad job of improving our outcomes. And this begs the question, why? And I think a really important thing to emphasize here is that we're doing all these different things to try to prevent infection, but there's sort of this low level of no matter what we do, we're never going to be able to make it zero. Our target is zero, and it's a great thing to shoot for, but it's going to almost be impossible to make it zero because there's just always going to be a low level of risk. And a great example of this was with the laminar flow that I was talking about before. With gowning, you have a certain amount of aerosolized particles that, decades later, now that we have laser particle counters, do a really good job of actually being able to quantify these very natural movements that we need to do in the OR. We can't get rid of all the particles that theoretically can inoculate our wound. I'd like to thank everybody in my lab for their help with all of this, and please let me know if you have any questions. Our next speaker is Dr. Bernthal, and his talk is on new technologies and techniques on the horizon.
Thanks so much, Dr. Urist. Privileged to be here with you and get the opportunity to present some of the new technologies and techniques on the horizon. I do have some disclosures to talk about, and we'll see how these are relevant, but I do work with several different companies, including a biologic company that's spun out from some of my research, which I'll highlight as we go through it. As discussed here today earlier, implant-related infection is a massive clinical problem. When we look at all-cause mortality rates, so this isn't morbidity, this isn't how much time or money or anything else, this is mortality. If a patient has PJI, they have a lower 5-year survivorship than being diagnosed with breast cancer or melanoma or Hodgkin's lymphoma. These are really massively burdensome. And in terms of the healthcare burden, we've seen this article pop up before, but no matter which prediction, which analysis we look at, the direct healthcare cost of PJI in the United States is just shy of $2 billion. With a lot of estimates saying the indirect costs, the missed work, and some of these other kind of time away costs add up to already $8 billion today. So I hope through the course of this, there's a couple of things we learned already. And one is that joint-related infection is complicated. We can categorize these into timing, that we have the early onset, which is the less than 3 months, the delayed onset, which is that 3-month to 2-year window, and then the true late onset, which comes after 2 years. But fundamentally, once you have a foreign body in the patient, it is at risk of contamination. Now, we think that 2/3 of the infections of PJIs come are initiated at the time of operation. And so that early onset and delayed onset, both we think primarily are seeded and contaminated at the time of surgery. And therefore, that is the bulk of infections, with the later hematogenous spread coming down the road. Um, I love these studies that people tackle looking at the microbiology of PJI, because I think we are going to enter a phase fairly soon that the term PJI is seen as archaic. When we think about prosthetic joint infection, that's a grab bag term, right? A staph biofilm that's an MSSA staph on an implant is a completely different disease process than an Enterobacter infection on an implant, or than a fungal infection on an implant. And so this term we use to study this, calling it PJI, is probably like the idea that we would study cancer by studying cancers. We don't. We study osteosarcoma or Ewing sarcoma or non-small cell lung cancer, but we don't study cancer. And I think over time, we really will push this field forward by understanding that every type of PJI is a bit different. I'm an orthopedic oncologist, and when you look at reconstructions like this, spinopelvic hardware, allograft being put in, endoprostheses being put in, this is colloquially, this is Russian roulette. I mean, if this gets infected, there is no backup plan. And we know Eric Henderson and the folks at Moffitt did a 5-institution study back in 2011 that showed that the #1 cause of failure, these type 4 failures, was infection. So the #1 reason that endoprostheses have to come out is infection by quite a bit. This data has been supported by publications, many since. Lee Jays out of Stanmore in England looked at 1,200 endoprostheses, 12% infection rate, by far the #1 cause of failure of these implants. And the Parity trial, arguably the best double-blinded randomized clinical trial put in endoprosthesis surgery in tumor reconstructions ever, looked at 5-day antibiotics versus 1-day antibiotics across dozens and dozens of institutions across many countries. And we found that there was a 16% infection rate in these endoprosthetic reconstructions. This problem is massive. Orthopedic oncology is high risk because of these long cases and lots of metal, but also we've got immunocompromised patients. So this becomes such an important subset to study. And we know no matter what type of orthopedics you practice, infection rates are higher in diabetics, smokers, elderly, obese. Any patient who is immunocompromised in any way is going to have worse outcomes. So what do we do? How do we improve the patients? Well, we try to deal with infection on a couple of different folds. We try and decrease contamination in the operating room. We try and perform immunomodulation, make our hosts more immune responsive. And then we try to address with exogenous antimicrobials. So in terms of immunomodulation, well, we try all these things. We get vitamin D supplementation. We get them to quit smoking and lose weight. But in essence, when you step back, you have all of these different areas in which we can take a bite at this apple of decreasing that infection rate. So there's preoperative patient control, there's intraoperative things we can do. There's things the surgeon can do with laminar airflow and draping protocols, techniques. Then we do things in terms of exposure control with surgical duration and OR traffic. But all of these, none of these solve the problem individually. All of them kind of let us get to a goal. So let's take these synergistic goals of decreasing contamination, increasing host response. That's why the majority of our patients don't get infected, is not because it was perfectly sterile that day, but because their host response was strong enough to address the bacterial challenge. And then we look at supporting with exogenous antimicrobials. The reality is that our operating rooms are not sterile. No matter what, every study that has looked at skin and fibers from gowns and drapes and gloves, bacteria is on just about everything despite our best attempts. And the bacteria is aerosolized. It is in the air of the room. And the reality is that these rooms, it is about decreasing contamination load as best as possible, but it is not getting to zero. So what's known today? What tools do we have? Well, in terms of exogenous things, we've got prophylactic antibiotics. Since 1970, we knew giving Ancef within an hour of the incision helps. That is absolutely proven. Everything else is debated. Antibiotic impregnated cement, there's database studies that show that this does work. There's also large prospective studies showing no difference. We debate whether putting antibiotics in the cement works. Vancomycin powder, using that like Parmesan cheese over the wound and sprinkling it along. There's some reasonable efficacy data in spine surgery. Arthroplasty is debatable, and trauma more recently has shown Vanc and Tobra powder seem to work in conjunction, but this still remains debated. Laminar flow data, we ask about spacesuits. There's data that says yes, data that says no. We know that these things continue to be debated. So when we talk about what we do and what we have at our disposal, there are really three categories now to add antimicrobials to our environment. We're going to assume we've made the host as robust as they can be. How can we support the host environment? Well, prevention, antibiotic powders and cements, surface protection, bacterial killing or anti-fouling coatings on the implant, and then a non-tethered to implant coating, something that elutes off and both protects the surface, but also cleans the neighborhood around the implant. So let's look at what's available around the world, and that depends on where you practice. In Europe, nanosilver coated implants are available. These nanosilver coatings are not approved in the United States, but in the UK, their group has looked at coating endoprostheses with nanosilver. And in one well-done study, they looked at coated implants having a non-significant increase in protection from implant fouling. They published a similar cohort a few years later and showed it did have a significant impact here. But what you'll see between these two studies is that what really changed was the control group. The control group now here has a 22% infection rate. The coated group actually didn't change over this period of time. In Japan, there's iodine-coated implants, and Professor Tsuchiya has a really nice single institution retrospective study showing iodine-coated implants with only a 2% infection rate. So this is encouraging, but this has not yet been reproduced at other institutions or anywhere else. In the US, there's a lot of regulatory constraints. We know that these sort of interventions are defined as class 1, 2, or 3. There's low risk, moderate to high risk, and then high risk interventions. We'll look at some of the things that are out there. So what do we currently use? Well, a lot of people use antibiotic in their cement. There is, as I said before, there's debate as to how efficacious this is. We also have some concerns when you get to higher dose antibiotics in the cement about impacting the mechanical properties of the cement. But Jay Parvizi back in 2007 had a very nice article showing that at least at his institution, putting antibiotics in the cement was beneficial. This remains debated. A lot of folks use antibiotic impregnated calcium sulfate beads. These are very good deliverables. The challenge in these are, number one, you're using calcium sulfate really not as it was FDA approved to use. You're using it as a delivery device. The calcium sulfate, there are cases of hypercalcemia. There's some challenges with seroma formation from the calcium sulfate breakdown, but this is a deliverable that people use and debate. There's also bone void fillers that folks have at their disposal. Again, off-label use in the United States to be loading these with antibiotics and delivering them. These are really for bone defects. Recently, there's an approval of a quaternary ammonium coating for, quaternary ammonium surface modification on implants. And this is a neat technology. This is a non-eluting technology that protects the surface of implants. The coating's covalently bound. It shows extremely effective 99.999 5-log killing bacteria found in the operating room. Was recently achieved a de novo approval, and this is recently made available. You can see here, again, some of the common bugs that we see. And the technology is indicated for protecting the implant surface. And this is really with this concept that the operating room is unfortunately not as sterile as we'd like, and we'd like that surface to be completely devoid of bacterial colonization. There are some investigational therapeutics that are really exciting. There are peptide therapeutics, and this is a potential treatment for biofilm that would break down biofilm on the surface of implants. That seems to be this one in particular seems to have good efficacy across many of the common biofilms on implants. And this is investigational in the clinical trial phase. Another clinical trial phase, and this one I was involved with, is another monoclonal antibody that breaks down biofilm. This is the idea with this technology is that there's a DNA binding protein that's essential to maintain structural stability of biofilms. And so this antibody actually goes down and breaks down the biofilm and allows antibiotics, which are given concurrently, to kill bacteria to eradicate an established infection. There's a new antibiotic-eluting spacer that is investigational, that the goal is to have your spacer in two-stage revisions eluting antibiotics at high concentrations. And this would allow us to decrease the time between second stage surgery, first stage and second stage surgery, where we'd get sort of a local high volume dose of antibiotics, high concentration dose. This is also investigational. And finally, another group that again I'm involved with is a surface modification that is applied by the surgeon in the operating room that allows the release of antimicrobials at very high dose off of existing implants. So this one is also in early investigational phase. So in essence, with that whirlwind, the scientific problem remains. Infection's a rare event in common surgery, and it's a common event in rare surgery. And either way, we very much struggle to get level 1 evidence. Level 1 data is few and far between. So we have these technologies, we have these interesting ideas, but showing efficacy and safety in randomized clinical trials is extremely challenging. I think we're making a lot of headway with these international collaborations. There's things that we do very well in the United States, and on the North American side, there's things that the Europeans do very well. Certainly, clinical trial enrollment is much more robust on their side of the pond, and sometimes the preclinical research is a little bit more robust on our side. And so working together, we can start to drive these innovations further, more quickly, more efficiently to help our patients. So through that whirlwind, orthopedic implant infections remain unsolved problems, devastating clinical and economic implications. The regulatory barriers remain challenging for innovation. The FDA is trying to do its part to keep patients safe and to keep us from creating resistant and persistent infections. Nonetheless, the barrier to entry for these new technologies is extremely high. There are a lot of new advances in devices, drugs, and combination products, and available technologies, frankly, depend on where you practice right now. Without the level 1 evidence we'd like, we're in a position where we will continue to push forward and hopefully establish that with collaborations, both locally and internationally. Thank you very much.
Our next speaker is Dr. Otero, and his talk is on infection management. 1-stage versus 2-stage treatment for periprosthetic joint infection, a prospective randomized trial.
And thank you all for joining as I give my presentation, 1-stage versus 2-stage treatment for prosthetic joint infection, a prospective randomized clinical trial. These are my disclosures. One stage versus two-stage treatment for prosthetic joint infection. Which is best? It's certainly been a long-standing debate for the last 5 decades. The problem is it's hard to make a decision because there's conflicting data. If we look at the European data, there's a meta-analysis of nearly 2,000 patients over 4 continents. One stage outperformed the two-stage, which some found surprising. If we look at the US data, it's the exact opposite. 16,000 patients, two-stage had better results than one stage. If we look at systematic reviews, over 1,000 studies reviewed, the overall quality of the studies was poor, and authors felt that high-quality randomized studies are needed. Here's another systematic review, which found no randomized controlled trials and little high-quality evidence addressing the issue. If we look at the INFORM trial across the pond, unfortunately, their primary outcome was not infection eradication. It was the WOMAC at 18 months and the cost of treatment. There was no host classification used and no standard infection criteria. So which is best? Well, one-stage data is encouraging, but it's difficult to interpret due to limited numbers of patients, organism exclusion, and comorbid patient exclusion. And while two-stage is the gold standard in the US, success is probably closer to 80% than the 90% often quoted. So patient convenience and the economic ramifications of two-stage demand reevaluation of this topic. So what was needed 7 years ago when we started this study? A multi-center, randomized, comparative clinical trial excluding only fungal organisms and immunosuppressed patients. The purpose of our study was to compare the 1-year efficacy of one-stage versus two-stage exchange treatment for PJI. We used the MSIS tiered outcome system, and success was defined as infection eradication. But we also wanted to determine the association between patient comorbidities, resistant organisms, and draining sinuses on outcome. This is an OREF-funded study. We have over 14 sites, and these are some of the PIs that were vital in helping us accomplish our work. So we had variable enrollment at the sites, so this must be taken into consideration. OrthoCarolina, our site, had over half of the patients enrolled. Inclusion criteria, all primary surgery, patient had to have a known organism, infection must have met MSIS criteria, previous IND was allowed, resistant organisms were allowed, and all host classifications were allowed. We excluded only fungal organisms, patients who were severely immunosuppressed, and patients whose wounds could not be closed with primary closure at the time of surgery. The sample size was calculated based on a 10% difference, and this was a non-inferiority study. So here's how we did it. One setup for extraction, one setup for implantation of either a spacer or an implant. Clean side is set up and covered during extraction. The dirty side is wheeled out of the room during cleaning. What goes on the dirty side? All extraction tools, all bony prep instruments, trial implants, and irrigation tools. What goes on the clean side? New, cleaner tractors and basic surgical instruments, final component assembly tools, final impactors, and finally, the implants. We had similar irrigation protocols between the groups. There was 3 stages of our irrigation, 3 liters of saline followed by dilute hydrogen peroxide soak, another 3-liter saline lavage, a dilute betadine soak, and finally, a third 3-liter bag of saline was irrigated through the joint. 1-stage and 2-stage patients both received 6 weeks IV antibiotics and 6 months of PO antibiotics. In the study sample, the groups were not statistically different in terms of demographic and host criteria. In 320 patients enrolled in the study, there were 273 available for 1-year analysis, and this discrepancy is primarily due to patients who had not yet received their 1-year follow-up questionnaires. So this is the data that we've all been waiting for. What is the efficacy of 1-stage versus 2-stage treatment in PJI at 1-year follow-up? 98% success for 1-stage and 92% success for 2-stage. Regarding a secondary question we had, does the comorbidity of the patient affect eradication? We performed a multivariable logistic regression analysis, and after adjusting for patient comorbidities, we found that one-stage treatment had nearly 4 times the odds of success, albeit with fairly wide confidence intervals. We asked whether organism affects infection eradication, and after controlling for resistant organisms, one-stage group had again 4 times the odd of infection eradication, albeit again with fairly wide confidence intervals. And then finally, does a draining sinus affect infection eradication? And after adjusting for a draining sinus, one-stage treatment had 3.5 times the odds of success. So in conclusion, the interim results of this randomized controlled trial indicate that the efficacy of one-stage and two-stage treatment for PJI are similar at 1 year. So why did we have such good results to date? First, this was a protocol-driven study. Both groups had similar surgical protocols, debridement, irrigation protocols. 2 instrument setups were used in all cases, 1 clean setup after the dirty instruments were removed from the room. Both patient groups received similar antibiotic protocols, both in cement and in postoperative antibiotic treatment. Finally, follow-up monitoring protocols were similar between groups. So while these results are encouraging at 1-year data, I want to emphasize that these are interim results. The caveat is that we need 2-year follow-up in order to make definitive conclusions. Additional limitations, there may have been selection bias. You saw that our site enrolled nearly half of the patients in the study, but when we looked at our results compared to other groups in the study, we had similar results. So I want to emphasize again that this is premature. It's too early to draw conclusions. However, this is the largest study of its type, especially compared with the EndoClinic and London studies, but we're still going to wait on 2-year follow-up. So is one-stage treatment best? We'll let you know next year.
Thank you to our master faculty for their excellent talks. While we've been speaking, I've seen a number of different questions coming in from the audience. Again, if there's any other questions that you haven't asked yet, please just use that question and answer button. So our first question here I see is, we've seen decent results from 2-stage and 1-stage exchange from multiple studies in the past. To what are the factors do you attribute the success at your center? Dr. Otero, could you take that, please?
Ken, that's a great question. And I think that's probably the most frequent question that we're asked. I really think that the difference in our results can be attributed to 2 main factors. First, this is a protocol-driven study. We're very strict about our protocol. Every patient who comes through the study receives the exact same protocol for treatment, both surgical, antibiotic, and post-op follow-up. And we think that this stringency is critical for the results. Second, I need to emphasize the importance of the thoroughness of debridement. When you do have a protocol-driven study and a protocol-driven surgical approach, there are certain steps that you take every single surgery to achieve success. And when you do this repeatedly, your patients receive a more thorough debridement, and you can count on your results a lot better.
Here is something that I saw that came in at the last talk. So now that we've seen that 1-stage may have as good of results as 2-stage, are we now going to do 1-stage for everybody? Dr. Otero, your thoughts?
Ken, that's another great question. It's really nice for patients when you can do 1-stage. It saves them another surgery. It saves them time. It saves them money. And patients don't want to sit and wait with a spacer for 3 months if they can avoid it. But the truth is, 1-stage is not for every patient. I think it's important to consider the inclusion criteria that we used in our study. And at least in the very early stages of rolling out 1-stage, if we do indeed determine that it's a viable option, we need to stick to the protocol for inclusion criteria. And I'll just reiterate those things. You don't want to do a 1-stage on a patient who had a previous surgery for infection with revision implants already in. We want to do a 1-stage for a patient who has a known organism so that we can tailor the antibiotic regimen to treat them effectively. And then finally, We don't want to include patients in one stage who have wounds that you can't close, because one of the biggest risk factors for reinfection is wound healing complications. So if you start from the get-go with a wound that's not healed, I think it's a setup for failure. And so I would love if we could do one stage for every patient, but there's simply going to be patients who don't qualify.
What's the most important surgical factor in achieving a successful outcome in exchange arthroplasty? What are your thoughts on this, Dr. Otero?
Another great question, Ken. When performing any surgery for infection, and one stage and two stage exchange are no different, the most important factor for achieving success is the thoroughness of debridement. These are surgeries that take time. This isn't a quick rinse out the pus and leave. You want to follow the protocol, debride the synovium, refresh the bone cuts to remove any osteomyelitis, debride the canals, and finally the irrigation protocol. So you have to go through all these steps. The thorough debridement is mandatory for a successful 1 or 2 stage.
This was a question that I saw after I finished my talk, so I'm going to pick it up. Somebody was asking, where does the biofilm hang out when it becomes infected? And this is actually, this was a great question, I thought, because this is something that we talk a lot about. You know, is it on the implant? Where is it on the implant? It's such a hard thing to sort of visualize. The way I like to think about this, it ends up in all the nooks and crannies that you can't get. And so if I'm washing an implant off, or if we're doing some type of surgical procedure, I can see the articular surface of the implant where they interact with everything, but that's not where we think the majority of the biofilm is located. It's all the backside surfaces that you can't get to and debride. The implant, between the implant and the bone, the backside of the polyethylene liner, and the implant itself. It's all the things that you can't get to, which is why it's so hard also to wash off. I see there's a series of questions here for Dr. Bernthal. Nick, do you just want to pick these up on your end?
I see a question here about which of these technologies are we betting on? Which one should we which is going to be the winner? And I think conceptually, I tend to view this a lot like we viewed cancer research, where there is going to be no individual winner. Bacteria have existed for millennia and will continue to exist. They will evolve ways around any intervention we have. And I think in essence, what the combination products in the end will be, what the solution will be, is some sort of coalescing of really good immunotherapy and something that makes our patients more robust as we go in, really good environmental management, decreasing contamination as best we can, and then these exogenous antimicrobials, adding them into the mix. And it will be some kind of combination of taking one of each from those categories that will allow us really to cut that infection rate down dramatically. But I'm just not convinced there's going to be an individual one that works. I see another question here about the difference, which of these approaches is really set up for prevention of infection versus treatment of infection. Yeah, thanks for picking up on that. I think this is really key. And so a lot of these peptide approaches and antibody approaches are really aimed at treatment of biofilm-associated PJI. And when we think about this distinction, I guess the way I like to talk about it in our lab meeting, because we try and hit on both of these when we do research in this space, is our threshold to accept an intervention that is aimed at treatment is much higher than our threshold at prevention. And so what we will tolerate in terms of risk, side effect profile, aggressiveness, once a patient has PJI, the horse is out of the barn. They are in a very tough spot. Based on the data we talked about here today, This is a patient with a very high 5-year mortality from this. And so this is someone who's willing to tolerate some risk to address this problem. When we talk about prevention, it's completely flipped, right? We have to think about the millions of patients undergoing joint replacements every year who don't get infected. So the second we start adding a lot of biologics and things with risk to them, things with any sort of increased cost, increased side effect profile, you're giving that to literally hundreds of patients for every single patient you're going to prevent an infection in. And so you can almost have no risk or side effect profile at all. So I think as you sort of tease through which approach to buy, which approach that you're going to say, this is one I'm going to establish, you have to have clarity in your head of what would your patient, what would your family member tolerate based on the situation they're in. And I think that's very different with someone who's dealing with an infection versus someone who's trying to prevent an infection.
Here is another question that I saw after I finished up my talk that I'll take care of now. So if the two stages don't work by removing the implants, why can't removing the implants get rid of the infection? And which is also actually a great question. And a lot of this is, again, because the biofilm is everywhere. And because it's so tolerant, even after you remove everything, there's going to be something relying on the tissue surface or on the backside of the bone that you're never going to be able to get rid of. And that's also actually why I always like to go back and use my example of tuberculosis or TB and just how unbelievably resilient the biofilm is. Well, that was a really great series of questions and answers. This has been a great discussion. Thank you so much for our faculty, for a great course, and most especially for our audience taking some time today. Thank you to our sponsor, Onkos. And finally, just a reminder that a recording of this masterclass will be available over the next couple of weeks at ryortho.com. So please keep an eye out for that. Have a good night, and this ends our masterclass on the subject of current concepts in the management of implant infection and bacterial contamination in complex orthopedic procedures.